So one of the highlights of SHARP is to hear from young researchers who've done research in areas allied to cardiovascular health. We have four presentations today that qualify for the SHARP Prize. And we'll start off the first presentation from Christopher Curran from NHS Ayrshire and Arran University Hospital Ayr, who will be telling us about the prevalence of liver fibrosis markers and the risk of all-cause mortality in people with type 2 diabetes. Christopher is joining us virtually, so welcome, Christopher. The stage is yours.
What I want to talk to you today about is non-alcoholic fatty liver disease, how we screen for it, and how we can use non-invasive risk scores to predict the risk of all-cause mortality, particularly in people with type 2 diabetes. So just briefly, some acknowledgements and that we have no conflicts of interest. So a little bit of background, first of all. Non-alcoholic fatty liver disease is where we have fat deposition in the liver in the absence of other causes of liver disease, such as alcohol, viral hepatitis, autoimmune or genetic causes. It's now the most common etiology of liver disease in developed countries, and I think will shortly be the most common cause worldwide. It's particularly important in patients with type 2 diabetes. They're particularly at risk of it, with some studies suggesting up to 70% of patients with type 2 diabetes will have some degree of NAFLD. It's quite important. Patients with NAFLD have an increased risk of mortality independently of other risk factors, and the main cause of death is cardiovascular disease. The difficulty comes in that NAFLD is quite a heterogeneous disease. The natural history is quite variable. Some patients will have simple steatosis with little risk of progression to significant fibrosis and end-stage liver disease, and others will progress quite quickly. The best tool that we have and the strongest predictor of long-term outcomes is hepatic fibrosis, as seen on biopsy through the microscope. However, this is clearly not a feasible screening tool in a population or in a disease with such a large prevalence. To this end, international guidelines recommend non-invasive assessment with risk scores based on clinical and biochemical variables. And the fibrosis 4 score, FIB4, is the one currently recommended by both the liver societies and the American College of Endocrinologists. Interestingly, these risk scores were initially developed to predict the presence of fibrosis in patients with hepatitis C, but they're now used as a screening tool for all types of liver disease. And while they have established diagnostic and prognostic performance in terms of liver-related events, their ability to predict mortality in patients with type 2 diabetics in particular is less clear, despite their recommendations in the guidelines. Here we can see a flow chart, a little bit complicated, and it shows you how this score can be used to categorize patients as low risk, where they can be discharged from further follow-up, or high risk, where they need more intensive monitoring and treatment and potentially referral to hepatology services. There's also an intermediate risk group who, after they've been identified, undergo second order testing with either further biochemical testing like the ELF blood test or liver stiffness through a FibroScan. Here you can see on the right hand side the variables that are used in the FIB4 test: age, liver enzymes, and platelet count. And the other scores that we studied, the NAFLD fibrosis score and the APRI score, use similar biochemical and clinical variables. So what we wished to do was, in a cohort of individuals with type 2 diabetes, describe the distribution of these scores and their association with all-cause mortality. So this is a retrospective cohort study of patients identified from primary care records in Ayrshire and Arran in Scotland. We extracted data for around 13,500 patients with type 2 diabetes using read codes from January 2012 and followed them up for 10 years or until death or emigration. We excluded patients with a diagnosis of alcoholic liver disease or viral hepatitis. And then to assess the association of these scores with all-cause mortality, we use multivariable Cox regression. This is the consort diagram and flow chart of the patients involved. We obtained data from around 80% of the GP practices in the area. And you can see there that we excluded a small number with alcoholic liver disease or viral hepatitis, which gave us around 12,500 cases with complete data after excluding a small number with incomplete data. Here you can see the baseline characteristics of our study population, and I think these would be relatively familiar to anybody who's done a diabetes clinic. Patients around 60 years old on average, around a 50-50 split of males and females, with a significant number of smokers and a BMI of over 30. You can also see the presence of comorbidities, the average HbA1c and renal function in the patients on the drugs that patients were prescribed for treatment of their diabetes. Importantly here, you can see we don't have the data on patients being prescribed SGLT2 inhibitors, given the time period the study was in. Here are the main page of results. On the left-hand side, we can see the risk scores, the FIB4, the NFS, and the APRI scores, and their distributions. And in the two middle columns, we can see the number of patients that died through follow-up, and then the hazard ratios, well, comparing the patients classified as high risk to those classified as low risk. And you can see that if a patient was classified as high risk, they had a significantly higher chance of dying through the course of follow-up, from around 2 to 4 times that as those patients categorized as low risk. You can see the distributions of patients categorized in low and high risk vary significantly as well between the scores. It's perhaps a little bit easier to see this visually through the Kaplan-Meier curves of cumulative all-cause mortality. And here it's quite clear that those categorized as high risk, the red lines, were at significantly higher chance of dying throughout the course of follow-up than those categorized as intermediate or low risk. That's for the FIB4, the NFS, and the APRI scores. In other analysis that we did, this is a forest plot of relative risk of all-cause mortality associated from high compared to low categories for the 3 scores by age. And you can see here that if a patient was categorized as high risk, well, they had a higher chance of mortality. But if you were categorized as high risk and you were under 65, that relative risk increase was significantly higher than those who were over 65. So I think this study, the strength of it, that we had a large cohort and we had minimal missing data. All of our patients have type 2 diabetes and we followed them up for a long period of time. And we believe this is a pragmatic assessment of current guidelines, as the current guidelines suggest that all patients with type 2 diabetes should be screened using these tools to see whether they're high or low risk. The weaknesses of the study were its nature was a retrospective design and therefore subject to unmeasured confounders that we didn't adjust for. Unfortunately, we didn't have any breakdown in the cause of mortality, although it's well established that this patient group, the main cause of death is cardiovascular disease, and then other liver-related outcomes following that. It also is quite a homogeneous population, and that's the nature of the southwest of the west of Scotland, where the vast majority of patients would be white Caucasian. There's also probably a significant inclusion of undiagnosed alcohol use or viral hepatitis. There was only a small number excluded, and that's due to the coding when we extracted the patient data. There was also no histological or radiological diagnosis of NAFLD in this. However, again, the guidelines don't suggest screening for NAFLD using ultrasound, as it has a low sensitivity for the diagnosis of this and may miss cases. Additionally, we know that the presence of steatosis on ultrasound is not a strong predictor of mortality compared to fibrosis as seen in a biopsy. Again, as I said earlier, this is pre-SGLT2, which would undoubtedly make a difference to the mortality of these patients. So in conclusion, we confirmed an association seen in previous studies that being classed as a higher risk group is associated with a higher chance of mortality, and we confirmed this specifically in patients with type 2 diabetes. We also identified the significantly higher increased relative risk of mortality in individuals under 65 years, classified as high risk compared with those over 65 years. But also importantly, what we found here was that if you can remember that first algorithm, it suggested onwards referral and assessment of patients in the intermediate and high risk categories. So looking at the FIB4 score, which is the one recommended by international guidelines, that will be about 23%. So around 1 in 4 patients of 12,000, that's about 3,000 patients who need further assessment. To give you an idea of that, there's 2 hospitals in Ayrshire, Crosshouse and University Hospital in Ayr. And in University Hospital in Ayr, there's 1 diabetologist and 1 gastroenterologist. And you could see how onwards referral of this number of patients could potentially demand a significant increased resource into assessing these patients. Therefore, we would recommend that further research is probably necessary on the optimal implementation of these tools and the best way, and whether there needs to be further second order testing with the ELF score, which, although recommended by NICE, is not in use all over Scotland particularly. It's only used by a few trusts in the UK, or FibroScan, although that requires purchase of a device and is mainly a secondary care test. So there's undoubtedly more work to be done to identify the highest risk group and those who'd be most likely to benefit from the kind of intensive identification of risk factors to improve their quality and quantity of life. Thanks very much for listening.
Questions from the audience for Christopher? I think in the interest of time, maybe 1 or 2 questions for him. I'll start. Did you look at the different components of the FIB4 score to see if any one particular component was driving the risk?
No, there wasn't one particular component. We didn't actually specifically break it down into that. However, I think it's notable in all the scores that ALT, AST and platelets feature strongly, and these have long been recognised to be the most important factors in predicting outcome for a variety of things in liver disease, whether that's death, development of HCC or episodes of decompensation.
Yeah, I was just wondering whether you'd see the same thing in metabolic syndrome and obesity as well, and not just in type 2 diabetes, because there's lots of overlap.